I'm here to talk about some of the work I've been doing looking at pre-eclampsia in Black and Brown women and birthers. So did some public engagement work. So currently I'm funded by Wellbeing of Women and I'm on an NIHR academic clinical fellowship. And I'm here to talk about the bit that I've circled clearly, which is part of our current funded research. So we are looking into a large data set at the University of Birmingham with over 4 million pregnancies, trying to look at the links between risk factors and the development of hypertensive disorders of pregnancy within different ethnic groups, and trying to establish the differences in those associations between risk factor and outcome when you compare those between different ethnicities. But we're keen to have a big kind of a PPI approach to this work to understand how we could potentially better predict pre-eclampsia within different racial groups. And we've also been doing some stakeholder engagement work too. So in terms of recruitment, we've got some collaborators, AFI Health and Black Mothers Matter, who are community groups within Bristol, who have been working closely with us and helping us to recruit women and birthers to the project to share their experiences and perspectives. But we've also did a lot of work on social media and with other community groups and through word of mouth to try and recruit people to these workshops. And essentially what we wanted to explore in the workshops was what women and birthers' current understanding of pre-eclampsia was, what they understood about how we currently predict pre-eclampsia, and then what their ideas were on how we might be able to do that better in the future, trying to really shape the plans for the research founded in what those women and birthers thought were most important, and particularly those from those ethnic groups, which unfortunately experience the disproportionate burden of pre-eclampsia. I wonder if I've skipped past a slide. I have. So race and pre-eclampsia. So Black women and birthers are 2 to 2.5 times more likely to develop pre-eclampsia and early onset pre-eclampsia. And not only do they have that increased risk, they also have an increased burden of the complications of that condition too. So they're more likely to have severe hypertension at diagnosis, more likely to require medication to treat the blood pressure, more likely to experience severe complications like strokes, pulmonary edema, and heart failure, and are less likely to have postnatal follow-up, but also have higher chances of long-term complications. Their babies are also experiencing a high burden of complications and more likely to be born preterm, very low birth weight, or stillborn. And we also, particularly in the UK, there's a 1.5 times the risk of South Asian women experiencing preterm pre-eclampsia. So important areas to look into how we might be able to manage these pregnancies better. So in terms of who we recruited, so you can see some pictures there. We travelled across the country, so did some workshops in Manchester, Bristol, and in London as well, to try and gain a breadth of experience and different perspectives. And we ran 8 workshops in just over a week across these 3 locations and recruited 44 women and birthers to those sessions. There was a predominantly Black and Black African group of participants that came along, but we did have some mixed ethnicity participants and some from other Asian backgrounds as well. But we did get a range of experiences, but we appreciate that the diversity of opinion and the diversity of ethnicities could have been more broad, but it really did give us some helpful insights into where we could take our research forward. So what did we ask? What did we want to know? So we looked at 2 clear areas. One area around what was your current understanding of pre-eclampsia and your experience within maternity care. What about aspirin? What do we do to predict your risk? And then we also wanted to explore the idea of designing a race-specific risk prediction tool. So obviously there are increasingly trusts are using tools such as the Fetal Medicine Foundation tool to more accurately predict someone's risk of developing preeclampsia. And this tries to account for that difference in risk associated with race or ethnicity by using that as a factor within the algorithm that predicts your risk. However, some of the studies have shown that it's more challenging to achieve that same level of accuracy of risk prediction with an increased false positive rate, particularly for Black women, and an increased screen positive rate for them as well, although potentially that is related to the increased incidence in those groups. So we really wanted to understand, well, would it be acceptable, would it be appropriate, and how might it work to actually have a different tool for different ethnicities based on whether those risk factors were the same with different groups. So in slightly more detail, we first explored what was the understanding of how we currently screen for preeclampsia, what preeclampsia was, and in the groups we spoke to, there was a clear lack of understanding around the fact that the placenta had anything to do with the development of preeclampsia, and very much the thought was around it's a high blood pressure problem, it's to do with your blood pressure, and things that put you at risk of getting high blood pressure are the things that put you at risk of developing preeclampsia. And while some of that may be true, it was really interesting to see people come on the journey as I tried to explain the concept of placental dysfunction in quite simple terms, and people really valued, but had their eyes open to that as a method of how preeclampsia developed. There was definitely an understanding that age, BMI, and family history were linked with the development of preeclampsia. But interestingly, particularly BMI among the Black and Black African women that attended the sessions was really a risk factor that didn't resonate with them, and they really struggled to relate to that as something that was relevant to them in their pregnancies. And I think that definitely comes from the fact that BMI is a risk factor that is well known to have been designed not particularly with ethnic diversity in mind, and many people did feel that it may not be relevant to them, which was quite interesting. Although many people acknowledged that they were told they were high risk in their pregnancy, it was difficult to pick apart. They didn't quite understand what they were at high risk of, whether that was preeclampsia, diabetes, VTE, any of the things that we try and predict in pregnancy and prevent. They seemed to be very much muddled, and they felt, I was a high-risk pregnancy, or I was consultant-led care, but not quite clear what that meant in terms of preeclampsia. And there was very little understanding that there were different pathways of care. There was an understanding that you might see the consultant, or might be consultant-led, but that you might see your midwife more often if you were at high risk of preeclampsia really wasn't understood. We talked about the use of aspirin, and many people felt that the function of aspirin was not explained to them. They were very worried about side effects, but overwhelmingly, they were unaware of the fact that aspirin was a prevention and not a treatment. And interestingly, there were some people who reported having been told to take aspirin, contacted their GP to get a prescription, and been told, you don't have high blood pressure, you don't need to take aspirin. So that was quite interesting to explore. We then moved on to think about what were people's ideas and views on using race as a way that we predict preeclampsia. Obviously, it forms part of the Fetal Medicine Foundation tool, but doesn't form part of current NICE guidance. And it's a question about, would that be acceptable? Would that be considered a way of actually discriminating against people, putting people into different categories? But overwhelmingly, people reported that this was an example to them of personalised care, an acknowledgement that there is a disparity in the risk of developing preeclampsia, and that it was an active approach to tackling that. And many people did report how they're very aware of the statistics that they face during their pregnancies, being 3 to 5 times more likely to die in pregnancy. All these statistics, the Embrace report is very well publicised, but actually what was the action coming from that? And they felt that this would be a demonstration that we were trying to improve their care. But it was very important to them that it was coupled with effective communication. And if we were going to use race as part of the way that we predict preeclampsia, that needed to be well explained, so that it was acceptable to people to be used. And we talked a little bit about how to define race. There was obviously the current within the UK. Obviously, it's different in different countries, but within the UK, there are ethnicity categories that the government use as part of the census, and they felt that for most part that reflected how they would want to identify. But they were quite interested in the concept of heritage. Was it relevant if you were from the Caribbean compared to if you were from Africa? And did that affect your risk? And so that has definitely been a feature in where we've taken this work forward. But again, they said if you were going to use this a subcategory of race, for example, thinking about someone's heritage or how long they'd lived in the country for, and if that would affect their risk, it must be explained why. We then discussed a potentially controversial and difficult topic in maternity care in terms of what are your views on being labelled high and low risk, and the additional screening or care that might come alongside that. And many people felt that qualitative labels of risk were the most useful: high, low, medium. But they felt that those categories should be assigned an action. So you should have, if you were going to be told you were medium risk, it needed to follow a care pathway that was different to that of being high or low. People did feel that a numerical score might be helpful, but they did acknowledge that many people might not be able to interpret that. But they felt that actually being told about their risk might help rationalize anxiety if it was tied to action. So being told you're high risk, they felt actually could be quite anxiety provoking, but if it was tied to something in terms of what we were going to do about it, they felt that that would be helpful. They were quite interested in the concept of your risk developing over time as we gain new information throughout your pregnancy. Could we update that risk? And they very much felt that one of the challenges they faced was being listened to when they came into maternity care. And if they were told, actually, you are at this risk, these are the things you need to look out for, and they felt that that was well communicated to them, it would empower them to advocate for themselves in gaining the care that they need. So then we explored what would they want from a tool that predicted individual risk of preeclampsia, but if those tools were specifically designed with Black and Brown women and birthers in mind. Many people wanted it to be integrated into their current healthcare, which they felt mostly was an app, whichever trusts they have been engaging with. Although some people were still using paper notes, they felt that they wanted it to be included in whichever way they were having their healthcare already delivered. They didn't want a new standalone thing. They felt that leaflets or additional information about preeclampsia and what to look out for would be helpful. But often they felt that actually that information is given to you at the start of pregnancy, but it often doesn't come into relevance until later on in terms of those symptoms to look out for. And so making that readily available throughout their care. They wanted to complete this information with a healthcare professional, and many people, particularly the assignment of a race category, they felt they really wanted to have their personal input into and make sure that that conversation was had about that they were put into the right category for them and was able to describe their race themselves. And they were really interested in, well, which factors for me increase my risk, and understanding that it could be different for different people and having that explained to them. But these are the things for you that are increasing your risk, but for someone else, it might be 3 completely different things. So what have we learned overall? Well, the understanding overall of preeclampsia was quite limited. And potentially that's a breakdown in communication. We spoke to people who were currently pregnant, who had been pregnant within the last 5 years. And with lots of areas of healthcare, we do our best to communicate what we can, and there's a lot of information to give. But there was definitely a gap in knowledge, then there's an area for improvement there. They really want us to explore heritage and ethnicity and how that links to your risk of preeclampsia. And so that, as I said previously, has factored into what are our next plans for taking this research forward. But they very much welcomed the idea of something race specific to account for potential differences in risk factors for preeclampsia. But overwhelmingly, effective communication was such an important factor for all the women and birthers that attended these sessions. They felt that that was something, a sensitive conversation, if we're using race, being informed about how to have that conversation was really important to them. So what next? Well, currently we're looking at the available tools, which one to use race in terms of risk prediction for preeclampsia in a systematic review, and looking at where race is used. Is it reported how well we can detect or predict preeclampsia within those individual racial groups, and kind of explore that a bit more and see what risk factors might be most useful in those groups. We are currently, as I mentioned before, exploring the link between race and different risk factors, and looking at, in different independent racial groups, what things predict preeclampsia best. And we are doing that in an international data set, but we also acknowledge the need to explore that within a UK data set. And that is our next kind of step with this work, to look at the ethnicity categories that we use within the UK, our most predominant populations of ethnic minorities, and then exploring those risk factors in more detail, with the view to seeing if we can develop a personalised risk prediction or multiple personalised risk prediction tools which account for those variations in those risk factors, which may be different for different racial groups. And then we want to package this up with education and training. Can we have this conversation? Can we have a sensitive conversation around race and risk with preeclampsia? Because I definitely know in my training, that is not something that formed a big part of our communication training, whether that's in medical school or later on. And it was definitely felt to be a gap from those that we spoke to. So that is a big focus for our funding application we're writing at the moment. So I'd just like to say thank you to all the women and birthers who took the time to express their interest. We had over 100 women and birthers that expressed interest initially, and 44 who attended our public engagement workshops. Thank you to my supervisory team and those who helped recruit participants, our collaborators, my colleagues at North Bristol Trust, Health Innovation West of England, and our charity partners, Affy Health and Black Mothers Matter. And obviously I couldn't be doing any of this work without my funders, Wellbeing of Women and NIHR, and also to those who attended our recent stakeholder engagement event. Thank you.
Thank you, Charlie. That is really fascinating and an incredibly important area. Well done. Congratulations to you and all the team, and keep going. Yeah, keep going.